All right, welcome everyone to the Palestine Program for Health and Human Rights webinar. We're focused on a really important topic today, and I think we have some amazing guests to talk through that with us. After a year of bombardment, starvation, displacement, detainment, and more indignities and violations than I could possibly list, it is difficult find something um, to continue to find something new to say about the humanitarian catastrophe in the Gaza Strip. Israel's actions have rendered much of Gaza uninhabitable, and almost all of its population has been struggling to escape what many increasingly believe is their certain death. The deterioration of the health system and the ability for the remaining health providers to deliver care, then, should not be seen as unintended consequences of Israel's actions, but perhaps another front of warfare. Just days ago, we witnessed hospital patients being burned alive in their beds. We've witnessed physicians being kidnapped from their hospitals, and we've witnessed the photos and testimonies of the torture they endured under detainment. We've witnessed children starving to death. And we even saw a young boy under the age of 1 become paralyzed in his legs due to a polio infection, the likes of which Gaza has not seen in nearly 30 years, and which was the topic of our most recent webinar, if you'd like to watch that, which is online. As we speak, the few remaining hospitals in the north of Gaza that are partially functional are under Israeli siege and evacuation orders. Indonesian hospital, for example, has been shelled with 15 medical staff and 30 patients still inside. They have not had fuel for generators in more than 3 days, and they are critically low on food and water. At least 2 patients in the ICU have reported as being killed or dying because there was no electricity for their oxygen. This is a story that we have seen told over and over in the past year, and yet as we convene today, we appear to be further than ever from any sort of political resolution that not only ends the violence, but ensures justice for victims and accountability for perpetrators. We can only assume then that we will continue to see deaths, yes, from guns and bombs, but also starvation, lack of medical care, and unmanaged infectious disease. How can we begin to understand what this means for the people of Gaza, both today and as we move into an uncertain future? When we hear today that official records indicate a confirmed death toll somewhere around 42 or 43,000, which was the official number provided by the Ministry of Health in Gaza to UN OCHA as of yesterday, how can we reckon with that number when all existing evidence, both from Gaza and from retrospective analysis of many other settings of war, indicates that the real death toll is likely much higher and that deaths from this war will continue far beyond the final bomb? These are the difficult but important topics that we'll be discussing today, and I'm very grateful that we have 2 exceptionally qualified people to help walk us through these issues. First, we will hear from Dr. Les Roberts, Professor Emeritus at Columbia University and a renowned expert in this type of research, having taken part in the field measurement of mortality in crisis, including Rwanda, 1994, more than 30 health zones in the Democratic Republic of Congo from 1999 to 2002, Iraq in 2004, Zimbabwe 2007, the Central African Republic in 2009, 2018, and 2022, and Sierra Leone in 2000 and 2014. We will then hear from Zeina Jamaluddine, a nutritionist and epidemiologist at the London School of Hygiene and Tropical Medicine. Her research is dedicated to improving the health of women and children, with a particular focus on those affected by conflict in the Middle East and North Africa region. She is interested in validating tools that reflect insecurities, quantifying health and nutrition inequalities, and evaluating the impact of various assistance interventions. Each speaker will speak for about 15 to 20 minutes, followed by a Q&A and then brief closing remarks. For the audience, please use the Q&A feature to submit questions, and please indicate if your question is directed to a specific person. To be clear, only panelists can see submitted questions, and we will likely not be able to address all of them. Questions cannot be submitted anonymously, but we do not call names during the Q&A. We will only pose the question. Speaker remarks are based on their own scholarship and experience. As such, they speak for themselves, not for Harvard University. That said, it's my pleasure to start us off with Dr. Les Roberts. Dr. Roberts, please take the floor.
Hi, Yara. Thank you so much for that. So, I'd actually like to start out by just covering three sort of general notions. One is, what is mortality? Why do we measure mortality? And what are some of the patterns that we tend to see again and again and again? So, National Geographic has called this the greatest graphic ever made, and it shows Napoleon's march from Germany on Moscow in 1812. And there's a line proportional to the size of his army, which started out at just under 250,000. He started in the fall. He arrived in Moscow just as winter got severe. And as you may recall, the Russians burned Moscow to the ground so his troops would not have shelter or food. And so very few days later, they turned around and started marching back, which is shown in black in this graphic. And down below is a little graphic corresponding to the temperature in degrees Fahrenheit for that black line retreat. And it bottoms out at negative 30 degrees Fahrenheit. And it turns out that Napoleon lost 98% of his troops, and most of it was to starvation and cold, not to violence. And so there's this sort of meme in Western culture where people say, oh, that's not a mistake. That's like invading Russia in winter, because it went really badly for the Germans in World War II as well. And what's really interesting is this was made about 70 years after Napoleon's march. And somehow this is the main way that history has been defined by that bad decision. Generally, in crises, we measure mortality as the crude mortality rate. That is, the deaths happening in some population per unit of time. And normally, we articulate that as deaths per 10,000 per day. In 1990, the CDC suggested that either one death per 10,000 per day or a doubling should be considered a health emergency. MSF's book, Refugee Health, and WHO signed on to this logic, so it quite quickly became the rule. One death per 10,000 per day, if you think with other units, is about 3 deaths per 1,000 per month, or 36 deaths per 1,000 per year. And there have been so many ways during times of war that people have gone out and attempted to measure mortality. In Syria, recently, a really great capture process happened where a group out in Berkeley took listings of violent deaths, looked at the overlap between them, the correlations between them, and was able to calculate, with some assumptions, how many deaths were missed by all the lists. That's one example. There have been many other techniques employed, snowball sampling. There was a really interesting study done in Ghana about 10 years ago where interviewing ancestors in a seance seemed to produce far better mortality estimates for a household than interviewing the members of that household. But the two main ways that we have measured mortality over the last half century in times of war have either been through surveillance or household surveys. And surveillance is never complete. In the United States, where we spend thousands and thousands of dollars per murder investigation, we think about a third of all murders are never detected. And there is nowhere in the world where every death is detected. And in most countries in the world, it's more in the ballpark of 50 to 70% of deaths that are detected. It works better in small defined areas like camps. Household surveys have worked in lots and lots of places. Now, why measure crude mortality? There are lots of other things that people consider to be a metric of how well a society is doing. In our country, sort of median income and inflation seem to be what everyone fixated on. But there's other things like the Human Development Index. There's a national happiness report that's put out every year. Their graphic for the last one is shown here on the right. Realize there's two huge, huge advantages over crude mortality compared to some of these other measures. One is when a crisis arises, crude mortality can double in a day, and we can measure it really quickly, unlike all these other measures. Moreover, uh, the world over, people understand what deaths are and have a sort of a common feeling about what a death means. Here's some data we collected in a household survey of 1,000 households in Iraq in 2004. And you may recall that the US military invaded in March of 2003. So essentially, we've got a year and 3 months, year and 2 months before, and a year and a half after. And with crude mortality, there's a really useful thing can happen. If I know the mortality rate before a crisis occurred, and I measure a mortality rate in a crisis as it's going on, as we've done here, I can attribute the excess deaths that happened as a result. In this case, violent deaths are shown in red, so the lion's share of excess deaths in Iraq were from violence. But often there is excess deaths from other causes. In the case of Iraq, deaths from auto accidents skyrocketed. It went up many-fold after the Allied invasion because people were terrified and drove really recklessly, and at all the major intersections, there were no longer police controlling the traffic as there always had been. So there are three great things we can get out of mortality data in times of crisis. We can learn important lessons. We can document what is in terms of making history known and hopefully correct. And we can improve the quality of healthcare services. In the first example, learning, there was a horrible hurricane struck what is now Bangladesh in 1970, and it killed over 200,000 people. And some folks from Johns Hopkins did a little bit dodgy, methodologically speaking, study, but estimated that there were these deaths. And interestingly, 22 years later, a virtually identical storm came in the exact same zone and went up the same swath, and the death rate was only a tiny fraction as high. And as a result of this, and they realized in that study done by the CDC in 2002, that hurricane shelters were the difference, the thing that protected people and kept them alive. And as a result, there were just thousands of hurricane shelters went up all around the Pacific Basin. And we've got lots of other examples, maybe the most dramatic one being a series of mortality studies that were done in Mozambique in that period of war, showing that if a child was born with an attended birth, they were less likely to die at the age of 2 or 3 or 4. And that really sort of hyper-energized the safe birthing movement in the 1990s. So there are times, my favorite example being when MSF documented deaths among Rohingya refugees in Cox's Bazar, where data can really carry a lot of sway in terms of what is. In this case, they did a survey. They estimated that over 6,000 Rohingya refugees had been killed by the government in Myanmar. And by chance, a study by Human Rights Watch that looked at satellite images essentially of villages getting burned, so a completely different outcome, aligned perfectly with the MSF study in terms of time and in terms of space where people reported that things happened. And it was astonishing how these two studies, particularly the MSF study, sort of made Aung San Suu Kyi, who had been the darling of the West, become persona non grata and made the condemnation of the government of Myanmar very, very strong and nearly universal. So there's a lot that mortality surveys can do to improve program quality. I was doing a survey in Katana Health Zone in 1999. I saw this little girl. She's very malnourished. She's very dehydrated. Her father said she just won't drink any water. I gave her my water bottle. She guzzled down a ton of water and then threw up. And I said, please, 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 can't you take her to a clinic? And he said, well, I don't have money to pay for the drugs and things that you have to pay for after. So I gave him some money. He said, okay. I went on my way. And when we came back 4 hours later, the little girl was still there and the father said, well, I didn't understand that the clinic near me really isn't open these days. So I got him to get in the car. We drove her to a hospital. And it turns out this girl's mother had died 3 months earlier from malaria. The father said how since the war had come, he'd not been able to sell any crops, so he never got any money, so he couldn't do anything. Was this girl destined to die because of the economy collapsing? Yes. Was she going to die because her mother wasn't taking care of her? Yes. Like, this excess mortality happens by so many mechanisms. And it was just remarkable in the 3 surveys in Katana Health Zone we did in the 4 years that follow, how we found so many things in our mortality surveys that changed our clinical treatment. The 2 most dramatic examples being there was almost no dysentery or meningitis illness or deaths reported in our surveys, but there was so much in the clinics, and we discovered that the underpaid staff were stealing the drugs for those 2 diseases because they were most expensive in the clinics. And finally, we were able to show that the mortality had gone down where IRC was working, not in the areas where no one was working. And we estimated that there were $200 spent for every death we averted. And so OFDA and CEDA were just so keen to give IRC money that all of a sudden we could start testing blood for HIV, which had never happened in that health zone before, and doing other things. There are certain patterns that arise in times of conflict again and again. Here is the main hospital in Sarajevo during the war. And on the left is the data coming from that hospital for the 2 years before Sarajevo was under siege, and then the period under siege. Admittedly, 20 or 30% of women had fled the city, so that may be part of the decline. But you'll notice the birth rate has gone way down in a population where abortion was the primary source of contraception. There just wasn't any stigma or shame, and it was sort of cost effective from a societal perspective to control births by abortions. So that's what they did. And when you look at this, you realize not only did the overall sort of pregnancy rate go down, but the fraction of pregnancies that women chose to take to term went down. So here's one example. It's Sarajevo. It's got to do with stress. It's got to do with choice. Years later, when I did a series of surveys in Eastern Congo and Western Congo where there was no war, in the East, where there was warfare, 2.5 times more pregnancies spontaneously terminated than in the West, where there are the same number of mosquitoes and the same amount of malaria and other things. So we see this again and again and again, that births go down in times of stress. Generally, deaths go up the most among the poorest people and the most rural people. People have a tendency of seeing deaths in their household as being closer in time and closer in family dynamics than our epiculture would tend to indicate, meaning that if there's a nephew who spent every 4th weekend at their house, it is very, very hard in many cultures not to say that was a death in my family. So it takes a lot of sort of cultural nuance to get deaths and family members defined properly in a survey. Surveillance almost always gets worse once a conflict begins. And interestingly, surveillance is so much better, and the internet is so much more accurate for the wealthiest countries. When I don't know something, I always ask my graduate students, what do you think? And I did this exercise with them, and a colleague did them with information science students at UNC Chapel Hill. And we showed them 5 wars in the late 20-teens and asked them which war has the highest violent specific mortality rate. And we asked them to break into groups and to do this by 3 different measures, to use a search engine, to use a constrained or academically rigorous search engine, and for someone in each group to go directly to whatever they thought was the best source. And like clockwork, they concluded that Venezuela or Syria were the most violent, and that either Mali or CAR was the least violent. And this isn't just wrong. This is wrong by probably a factor of 10. And it just shows how the internet works, where people and society is really connected and sharing things in a digital format. And that's just not happening in the world's poorest and neediest places. I'd like to close with, there was a pattern that we've seen again and again and again. And interestingly, there's an article written in the Tablet a few months ago saying how Gaza Ministry of Health fakes casualty numbers. It was written by someone at the Wharton School of Business. And they had a couple of graphics in there showing how on days when the most children died, there weren't as many adults dying. And this particularly dramatic one, on days when the most men died, there weren't many women dying. And on the days when the most women died, there weren't many men dying. And they said this is proof of data fraud. We saw in Fallujah, we saw in Syria, when urban warfare is going on and one side is stronger and taking over an area, they bomb an area like crazy, and then they go in with troops and try to take control. And men in general, soldiers in particular, are way better at protecting themselves from bombing events. And B, bombs kill everyone haphazardly, and most people are women and children. So it completely makes sense that on days when there's bombing, women and children die more. And then when soldiers come in, they primarily shoot people that are shooting at them. So of course, they almost exclusively shoot men. This completely makes sense. But if you're not used to sort of the patterns that arise in mortality, because it is not quote unquote random, it must be fake. All right, I'd like to stop here and start talking about Gaza.
Thank you so much, Dr. Roberts, for, I think, really doing an amazing job setting the stage, telling us what people like you who are experts in this field think about. And in my mind, you did such a great job illustrating just how multifaceted the study of excess mortality is in these types of settings. I mean, even if we are able to consider and look beyond, bombing and violent deaths and consider things like illness and starvation, to hear in your description how issues like lack of contraception or lack of police on the roads and the stress and inability of people to drive as carefully as they might also contributes, and I think would rightfully be considered deaths as a result of conflict, even though we're not looking at them in that way. And I think you did a perfect job setting the stage for our next presenter, who is going to kind of drill down more on the specific context of the Gaza Strip, and we will come back to you, Les, I'm sure, for a great Q&A. So Zeina, I would like to turn to you and the really innovative and groundbreaking work that you and your team are doing. We're really excited to hear from you and build off of this extensive history that Les has provided. So I will turn to you.
Thank you, Yara, and thank you, Les, and everyone for the invite. And can you see my screen? Okay, perfect. So, I just want to talk a bit about the reflections of mortality in Gaza in the past year and what sort of some of it might be very intuitive for someone like Les, who's worked a lot in this conflict, but some stuff that I've reflected upon in Gaza, and I'll focus on three big topics. The first one is health information system, then on the projections, and some on data collection. So in terms of health information system, it might be a bit intuitive to say that in countries where we have good health information systems, usually they're high income and not always, helps us track mortalities. But in a lot of the countries where there is conflict, health information systems sometimes also don't exist. And this is something that we've seen in Sudan. But also that is important when it comes to tracking mortality for crisis and conflict or wars, but also when it comes to climate change or other disasters. And so one big thing that I want to start with is a huge advocacy on investing in health information systems, because I think that helped Gaza a lot at the beginning of the war. And why would I say that? Because in fact, going back a year ago when President Biden said that he does not believe the numbers of Gaza, the Ministry of Health, what they were able to do is actually put out a detailed report, and maybe some of you have seen the list of names. But what Gaza also did was keep on putting these reports, and today they just released another list of 800 names, of 800 pages, of names of people who were killed in Gaza. And these included an ID and multiple things. And when I saw this list, because I worked in that setting, I analyzed this data because they were able to release these names. As an epidemiologist, I wanted to show what was happening in Gaza in the first 20 days of the war. And so as we first, maybe most of you have seen these, there has been some analysis to show the population that was killed in Gaza. And as you can see, it's quite at the beginning of the war, like Les mentioned, it was a bombing. And a lot of the mortality actually happened across all the population, across all the ages. And it looks like a population pyramid, but it's actually the mortality of people who were killed in Gaza. And I just want to talk about the issue of the perfect victims, because a lot of the media has been pushing the idea of children and women. And I think it's important to talk about also the men who are dying, men who are going to get food, men who are healthcare workers, men who are and combatants and all of it together. But I think it's worth all of us together and try to change the narrative of what is happening with the concept of a perfect victim, a baby, a woman, and men are 30 to 35 years old. What are we talking? What are we saying? And so I just want to say that there was another time where the numbers in Gaza have been questioned, and they will always be questioned, but there was a questioning of the numbers in May. And why did this happen? Because actually OCHA released that there are 36,000 who died, but what they ended up doing is putting a small asterisk. And this asterisk has caused everyone to come and question the numbers again. And the asterisk was that around 24,000 were identified. So I know the names of 24,000, but I don't know the names of the 10,000 difference. And so are these really dead? Are these not dead? What do you mean? And how many are under the rubble? And so I took it upon myself to really talk about this aspect because, in fact, the Ministry of Health, who has used the health information system, what Les also mentioned is that with wars, health information systems degrade. And what also has happened in Gaza is there was a direct attack on hospitals, on healthcare workers able to enter the data, and healthcare workers were killed. Data collectors were, the sources of information degrade. And you could see this perfectly in Gaza. And so I want to share with you just quickly what happened in terms of the numbers. So by the end of June, there was around like 35,000 who were killed, 36,000 who were killed, as reported by the Ministry of Health. But that actually came from multiple different lists. It included the hospital list, which I mentioned at the beginning, which was the list of basically any mortality that comes to the morgue in the hospitals. And at the beginning, 9 out of 9 hospitals were reporting that. When the attack on Al-Shifa Hospital happened, and you could see that in November, what the ministry then started to have the list of those identified or named, and then including those unidentified. So when someone says in the media or even in Palestinian Red Crescent coming and saying, we have 3-4 bodies here, we have 5 bodies, we don't put the names of, they started compiling that. But as you can see, as the war went on, the attack on the hospitals increased, but also what also happened is the number of hospital reporting decreased. So at the beginning, it was 9 out of 9. Then a Shifa hospital attack, 6 out of 9 reported the list, and then 3 out of 9, and then 2 out of 9 when Nasser Hospital was under siege. And then the ministry was able to pick up again because the war was not always constant. And in some places, it was a bit where some areas where they were able to pick back again. And then we're able to report on 5 out of 9 hospitals. And I do think that this also shows the system in Gaza and how people in Gaza are trying to make sure that the system are still able to work to report on these numbers. But what they also did is they complemented this with a survey. So in January, what they started to ask people is whether it's possible for them to fill with the ID of the people, putting the ID, putting identification and names, to complement it all with a survey. And so the numbers that you're seeing being published by the Ministry of Health actually includes hospital, survey, and those that are unidentified. But does this really mean that this is the only mortality in Gaza? No, because as also Les has mentioned, it's actually the issue of surveillance becoming less and less able to track, and so on. So we are hopefully waiting for an analysis that I hope it comes out in the next 2 weeks, where we can show you some of the capture-recapture analysis that we've done by combining different lists and trying to understand what is the trauma mortality in Gaza during certain periods. But I just wanted to reflect on the first important point of health information systems. The second point is on projection. So as I said, and you maybe are a bit familiar with Gaza context, is that by December, the attack on hospitals started to increase, and there was a lot of concern about what is the indirect effect or the non-violent effect of war. So when we talk about infectious diseases, maternal mortality, that are not caused directly by a bomb falling on you, but rather by the fact that you cannot access the care you need. And so we were asked to do, of course, a team between London School and Hopkins University, and we have done projections to project what would be the excess mortality from different non-violent mortalities in Gaza. And we've done 3 different scenarios, hoping really that in February, we would have a ceasefire, a permanent ceasefire, and another scenario where we would have a status quo, and a scenario where we would have an escalation. So the escalation included the attack on Rafah. At that point, there was not an attack on Rafah, and we at that point projected that an attack of Rafah, what would happen if an attack on Rafah also happens in a projection, in an escalation scenario. So we have a report that's online. It has a huge appendix. Anyone who wants to have a look at it, please feel free. And we have projected 3 different scenarios from February till August on what would happen in 3 different scenarios. And as I'm not going to go into this again, but I think Les has described it really nicely when about such a gruesome topic to even say nicely, but attacks, basically mortality occurs from aerial ground invasion and direct death, and there is the indirect death due to poor shelter, disruption of healthcare system, sanitation, water, and insufficient food. And so this also gets compounded with if an epidemic occurs. And maybe if like people are very familiar with COVID-19 epidemic, but what I mean also here is the fact that Gaza did not have polio, Gaza does not have cholera. And so if polio or cholera or some of these occur in Gaza, what would happen? Because epidemics will lead to a lot of mortality. And so we projected from trauma death, epidemic, endemics, and maternal newborn death that are not linked to trauma. So a mom who needs blood and who majority of births are going to be fine. But if the birth is actually of high risk and actually leads to a lot of bleeding, there is no blood in the hospitals. We've started to hear reports of hysterectomies in order to save the lives of women, but it's also possible that women actually bled to death. And we've started to see some of these cases. The other big thing about Gaza that I will always argue about is the fact that before the war, Gaza had a high population of NCDs. And actually, the big concern was actually you have a heart attack and you're not able to go to a hospital and get the treatment and your survival. And so that is what we projected. We also projected malnutrition because also we've seen, but also we know how malnutrition plays a role in all these different diseases in different ways. We omitted accidents because it was hard to do. We omitted a lot of things, actually. We omitted the COPD, which I would argue is also an excess mortality. So COPD is chronic obstetric pulmonary diseases. So, and it's very relevant when you're inhaling all this dust. So your excess mortality might increase from inhaling all the dust of the war. And so as epidemiologists, we look at risk factors. So we have the different diseases, so infectious diseases, maternal, newborn, and CDs. And we project in the three different scenarios, a ceasefire, status quo, escalation, what would be the prevalence of the measure or the number of the different indicators. So WASH, shelter, so access to so crowdiness, how many people are living together, because all of that plays a huge role with infectious disease, right? And access to hospital is primary needed for NCDs, and so on. And so I'm not going to go into all the different models. Please feel free to look at them. But we've projected for infectious diseases. What we've done is actually we created a new model by looking at dynamics of immunity and how it will decrease. So Gaza at the beginning of the war had 100% immunization. If you go back to basically the numbers from MIGS and UNICEF, and it was very highly a vaccinated population. And what's happened with the war is vaccine coverage decreased and the efficiency of basically, so we wanted to really we built a model to look at how the basically track infections. But also what we did is we've asked structured expert elicitation about some case fatality ratios from different infectious diseases, but we also looked at the literature because some of the stuff is available from the literature. So we've done this exercise. And in terms of infectious diseases, when we look at the ones that we considered as leading to the most excess mortality, they were actually COVID-19, influenza, and RSVs and pneumococcal diseases. But this is when we talk about basically infectious diseases as endemics. And so before the war, they were not that many. And sorry, I didn't talk about this figure here before, but this is COVID-19 mortality. So before the war, mortality from infectious diseases was very low, with around 200. It increased with COVID-19, like all countries, and then decreased when vaccination occurred. And so the counterfactual, or the before the war, was very low, was around 200. But if you add on top of it in 6 months from infectious disease, it would be, we were projecting that under different scenarios, it could possibly reach around 3,000 in an escalation scenario. Now, the endemics are more, would lead to more excess mortalities, of course. Epidemics, sorry, my bad. So epidemics would lead to more excess mortalities, but we also wanted to see what is the probability of an epidemic occurring. The most likely ones based on expert elicitations and the literature were cholera, measles, polio, and the vaccine-derived one, and the wild-type one, and pneumococcal meningitis. Sadly, to be honest, when we were doing that, there was no polio in Gaza yet detected. And the moment it was detected in Gaza, it was more like we've done these projections, we showed what the impact would be, and then a vaccine-derived one, polio, has occurred in Gaza. And so actually what I want to reflect upon all of this is, as an epidemiologist or person who works in public health, the predictability of all of this from different wars, whether Syria, and we've seen that in Sudan and different ways, is a scenario that we see reoccur in different conflicts. And so, and cholera has not yet been observed in Gaza, but the projections are that if cholera occurs, it would lead to really a lot high excess mortality. If you look at the confidence interval, the upper limit could reach to 120,000. Now, what I also want to talk about is polio, is that the ministry was able to launch a polio vaccination campaign, and they did the first round, but also now they're starting the second round. And there are households where they went in to them and the father told them that their kids died. And so the direct effect of the war, so they died from a bomb. And so sometimes it seems like like putting a scotch tape on an open wound, and a whole point of asking for humanitarian efforts with a ceasefire, and that these interventions that we're talking in public health should always be pushed with also a call for an implementation of a ceasefire, because bombs, we're putting vaccination and doing all these campaigns, and bombs are still occurring. And we've projected in malnutrition, and I don't go into malnutrition. I'm very happy to go into it if you guys want, but later on. I think hope I'm not all taking a lot of time. So in terms of maternal newborn death, this is the only model where we previously had a model built before. And this is another point for people who work in public health that I would say is maybe start thinking of how we could build models and understand different excess mortalities. Maybe because when a crisis occurs, it's not the time to start creating new ones, and it's the time to have good models in. And so research and empirical research that people do all feeds into all of that. And so this was the only model that was basically before, and has its own problems, like all models, of course. But it actually was a life-saved tool. So how many lives would be saved if we implement different interventions for maternal and newborn care? So if we have, for example, NICUs in the hospitals, how many lives of premature babies would be saved? And so we did the opposite. We actually decreased the interventions. And so technically it was made to save lives. We ended up doing the reverse. And so basically we're saying that women are not able to attend antenatal care. Women are not able to go to healthcare facilities to give birth. So they're delivering at home. So they don't have access to life-saving interventions. Women are not able to breastfeed their children. That's because of multiple reasons in conflict. And increase of food insecurity actually also might lead to basically neonatal and miscarriages. And so we took these, and I'm not going to go into all of the details, but for example, we take the healthcare facilities. Before the war, 99% of the women delivered in a healthcare facility. If a ceasefire happens, we know that not all hospitals are still working, and it's around 90%, and the status quo 80%, and in an escalation around 70%. And so these are assumptions, of course, that we're putting in, but we to project excess mortality. And so what we see is, in terms of maternal, neonatal, stillbirth, is that, of course, the gray line is what would have happened before the war. So what would be the mortality from maternal mortality that we see before the war? And then the three lines actually represent the projection. So in purple, we have up to February, where we started the projections. And then we have in the ceasefire scenario in gray, and in purple, the escalation scenario. And these maternal mortality ratios, neonatal mortality rates, we've seen them actually go back 20 and 30 years ago in Gaza. So the numbers actually show numbers that we've seen years ago in Gaza. It actually shows around 330 excess maternal and neonatal death in an escalation scenario. It's a small proportion, but it's very important to also talk about a reversion in number in healthcare facility ability to save newborn and maternal and newborn maternal lives. Finally, I want to talk about NCDs. So NCDs is the hardest one to do, because I think a lot of the interactions happen between hypertension, diabetes, and all of that. And if anyone wants to do focus on NCDs, I think I would say to people, have good models for this. I think it's in humanitarian research being explored more and more. But in terms of how the wars are becoming and how epidemiological transition is happening, whether Syria, whether Ukraine, whether Gaza, Lebanon, I think it's important not to forget NCDs. And so we've projected in terms of type 1 diabetes, chronic kidney diseases, ischemic heart diseases, and stroke, basically using whether people have access to treatment or not from the literature. And I think this, like a lot of this could always be improved, right? So we have projected that the majority excess mortality would come from ischemic heart diseases and strokes because people are not able to access the care. So they're not able to access cardiac care, they're not able to access neurologists. And for type 1 diabetes, it was really the interruption of insulin. So a type 1 diabetic patient cannot have access to insulin. We know quite well that their mortality increases quite a lot. The same thing with chronic kidney diseases, and now we're starting to see in Lebanon also a huge call for chronic kidney diseases patients. And so these are our projections. This is just to also say these are projections, not predictions. So we are projecting what might happen and in different scenarios. Sadly, we were talking at the beginning when the projections came out about how many lives could be saved if we have a ceasefire now. But we're in a situation where we're talking about escalations. And so finally, I want to just end on a final note about data collection during conflict. And I think also Les has talked about it, but from previous work, a lot of data that comes from conflict really comes quite selectively because there is like areas that are, there is more wars, there's areas there's less war. And sometimes like the most areas where there's least active war, we know more information on. And so we've done this back when a few years ago about Syria to map out reproductive, maternal, newborn indicators. And you could see that in some areas we have quite a lot of data. So the darker it is, the more data we have about these areas. But in some places where we know that Raqqa, Deir ez-Zor, and different places, Damascus, like there is limited data that started to come out for multiple different reasons. But that also shows us the selectiveness of data that we get or gather from conflicts. And so capture recapture is a way, and there are other ways to try to understand that. But in Gaza, with a very, very preliminary data that I will just talk about is, you remember I mentioned, maybe I didn't, that there is an agency in Gaza called UNRWA, which actually is the main provider of primary healthcare and education in Gaza. And before the war, on October the 7th, there were around 15,000 women that were pregnant as the start of the war. Now, UNRWA had excellent electronic health system, actually. And as the war progressed, they didn't collect quite a lot of data, but then they wanted to start to understand what happened to these women. So in West Bank, they started to call people in Gaza to do some sort of a follow-up. And actually, there was quite a big response rate, around 70%. And in the survey, like just in terms of mortality, there were 60 pregnancy-related mortalities. So women who died during pregnancy during the war. But if we actually take the Ministry of Health data and actually the other side where we don't know that, so the 5,000 that did not respond, okay, and we link to the Ministry of Health, so, and we see based on the mother's expected delivery date, so if she died before her expected delivery date, we actually get around 149 extra deaths. And so I would just say one thing about like the selectiveness of data and how we interpret all of that and how we understand data from conflict. And so just a point of caution about all of this. So thank you so much. And I hope this was helpful and looking forward to the Q&A.
Thank you so much, Zeina. That was so incredibly informative. And I know, as you commented, there's so much more you could have gone into detail on, including issues like malnutrition, and maybe we will get into that. So I want to turn now to a few questions, and I want to remind the audience you can submit questions via the Q&A feature. We will not read your name if we get to your question. So one of the first questions I personally want to bring up is, and both of you address this in different ways, is, as early as, I guess, was it October, November, when the US president questioned the mortality numbers because of the source, which was the Ministry of Health in Gaza. We continued to kind of see this denial, essentially, that things were as bad as they were, that mortality was as high as it was, that in general the situation had deteriorated in the way that I think many of us saw on hundreds, thousands of hours of video and photos. So Les, I want to first ask you, have you seen this in other contexts, this kind of questioning of mortality numbers, of methods, of ministries of health of countries which in Gaza, as in essentially every other country, would be the responsible entity to kind of collect this information? Can you talk to us a little bit about that?
Absolutely. We have seen this time and time again. The United States invades Afghanistan or invades Iraq, and researchers from the CDC measure the highest mortality that had ever been measured in Afghanistan. Oh, and the government does not allow that to be published. And death tolls come out of Iraq from really passive surveillance systems looking at official deaths in Baghdad and newspaper reports that are like 10% complete. And so that's what the US government cites. And it's not just the US. We see this the world over. MSF declares cholera when the government of Ethiopia doesn't want it, and they kick MSF out of the country. Like, the perpetrators of violence almost always downplay the death toll and almost always look for weaknesses and criticisms in what's being done. And this has the effect, and I believe this is happening with the Ministry of Health and Hamas, of making the reporting extremely conservative because they're terrified that they'll have a double count that someone on the outside can find and hold up against them.
Thank you. That's really interesting. Have you found, Les, that especially as the time from the war passes and we're able to get more accurate retrospective data, do these perpetrators often, do they just kind of ignore the new data, or is there corrections, apologies? Have you seen that?
So this is getting a little more complex. And the answer is it depends. It was really stunning how I was involved in two studies about deaths in Iraq. One in 2004, when US public opinion was strongly, like 70%, in favor of the invasion. And it got virtually no press coverage in the United States. My highest profile interview, or any of the authors, was with Amy Goodman on Democracy Now! 2 years later, the study essentially was repeated and twice as large, and it was on the front page of every newspaper. Everyone believed it, and public opinion was at that point strongly against the invasion of Iraq. So it changes for that reason. But more importantly, sometimes there is data that is out there, like happened in Biafra, that's not really fully understood and not really completely acceptable. And so it gets processed slowly over time. And then eventually we can say, oh, yes, the Nigerian government was shooting down Red Cross airplanes full of food. And that was really, really unacceptable and untenable. There's a tendency, if documented reasonably well, for the quality of evidence to float upwards as time goes on. I'll stop there. Thanks.
Thank you, Les. That's a great historical perspective on this, and I'm interested to see how this will be interpreted in the coming years, decades, and generations. Zeina, I want to turn to you. We've gotten several questions regarding mental health and how they do or do not fit into the projections. One comments that we know, of course, war destroys mental health through many mechanisms. And I note that you had purposefully omitted something like suicide from your projections, I assume for reasons of logistic difficulty and others. Could you talk a little bit about how, so maybe two questions. How might mental health fit into projections? And can you talk to us a little bit about the logistical challenges with including that and how you thought about it as you considered this death toll?
Yeah. So I don't know if this is the answer you want to hear, but it's more like what happened is that when we were doing the projections, we were very short on time. And so
Mm.
some people wanted us to also do a projection on mental health. And at that point, it was more like a mental health as an outcome. And to be very honest, at that point, I felt that if we come up and do projections on how many have PTSD, or not even post, I don't know, depression and all of that, and interventions are not coming in, uh, it felt at that point we were very tight on time, and it is very, very important, but we focused rather just on excess mortality. We talked a lot about how do we include mental health, but then also we need some indicators in terms of numbers, so effect or risk, or like this aspect needed to go into the models, and we need more studies being done on that in order to put those as a risk factor in terms of mortality. And so I think that also we did not include them. Of course, it is a limitation, and we have 70 pages of limitations.
Mhm.
And it is definitely a limitation. And how it might play a role, it might play a role in terms of stress, the increased heart diseases, hypertension. Like if we start talking, but I'm sure there are better mental health experts than me to talk about this. I'm a nutritionist, not really work a lot on mental health.
Okay, so I mean, this is I think there's some students on the call. This is, I think, an important aspect of us to continue to look at and
Definitely, definitely. No, I just wanted to say that when we
yeah.
did it, we felt that okay, we have 2 million people. How are we gonna divide them into depression? And I
Hmm.
think it's very important to see how to do mental health properly, and the intervention and the implication of all the mental health of all of what's happening on the long term is going to be hugely important to focus on. And the earlier we focus on it, the more prepared we are at intervening.
Definitely. Thank you. Les, I want to come back to you. We have a question or a couple questions on um, we've heard, so this 42,000 number is the kind of confirmed deaths that have been reported. I guess perhaps we would quote if you want to comment on that language. But we know undoubtedly that there are many hundreds, thousands, perhaps tens of thousands of deaths, people trapped or caught in the rubble. Their families have not reported their death because they're afraid to leave their house. How do we account for these kind of, in many ways, uncountable deaths? And how do we think about that? Does clarity come in time, or will this always be kind of a crude estimate in some ways?
It's always going to be a crude estimate in some ways. We don't even have a perfect estimate from the 9/11 attacks in the US. There's a little bit of sort of questioning about a few cases. So, thought number one, and the most important one from my perspective, is would I make a different judgment if I was the US government and giving weapons to an army? Would I care whether it was 40,000 or 60,000? I don't think so. I think that um, I think that this is just so untenable that we shouldn't get too fixated on the fact that we're undercounting.
Mhm.
Thought one. Thought two, just before, like in 2022, I think it was, maybe it's 2021, WHO did an assessment of mortality surveillance in Gaza. And at that point, they were missing 13% of deaths. Like, that's so much better than most countries in the Middle East. The year we invaded Iraq, the year before, most deaths were not recorded by the government. And so, starting at 87%, as two brilliant reviews in the Lancet in December showed, in the first couple months of the war, the government's numbers were really robust. They were probably low, but they weren't made up. There wasn't duplication. Now It's messier. I promise you there are duplicate deaths when they include newspaper reports in with the tallies. Not a lot. I'm not saying it's 10%. I'm not saying it's a big deal. I'm saying for the critics, they can find a couple here and there. And so we are never going to have a perfect toll. We probably, as has happened in Vietnam, are going to have a census done and demographers will estimate who's missing. We will probably, as has happened repeatedly at the end of the war, have people go and interview and do really sophisticated interviews, not just about your family, but about all the siblings who were ever born to you and where were they and where are they now. And we'll probably come up with a crude estimate with a wide confidence interval that will be way higher than the number we're using now. But I would hope it just doesn't matter. I would hope as humanitarians, 40,000, 60,000, they're both sort of untenable. Don't get me wrong. I am not like one-sided in this. I think if you look across all of Israel and think about adults who could vote that were in favor of a two-state solution, the idea of attacking a sort of folk rock festival full of hippies is like the worst thing you could do for bringing sort of peace and calm. And thus, like, I find what Hamas did is untenable in the beginning, but whether it's an overreaction of 40,000 deaths or an overreaction of 60,000 deaths, our horror at the overreaction, like, just should not get caught up in the numbers when we're absolutely sure what the rock bottom is. I'll stop there.
Thank you. Zeina, I know you had kind of mentioned, and because this has been, we've seen these IPC reports coming out since the spring, and we've heard in your analysis the role that malnutrition is not just in and of itself a threat to health, but can make people more susceptible to, death by diseases and other things. Can you comment a little bit on how you look at the issue of not just, I guess, starvation and food insecurity, which we know, especially in the North, is very high right now, but on malnutrition and kind of how it weaves its way into all these other outcomes?
Yeah, thank you so much for this question. Okay, so I will answer first of all the issue of malnutrition as what happened in Gaza. So at the beginning of the war, around 1% of children were actually wasting, what we consider as wasting in terms of basically thin. When you see these very thin children, and it was around 1%. And we've never talked about malnutrition in terms of acute malnutrition. We talk about stunting, so short children, but we don't talk in that setting about acute malnutrition. What happened is that food availability became less and less. Trucks were restricted from coming in. We started to see this phenomena of airdrops happening that really did not give that much calories. And to be honest, the dock that was put in actually costed a lot of money and barely got in 400 trucks. And you can get the equivalent. So all of that showed that we saw a humanitarianism and getting food in Gaza. Then there was the killing of the healthcare workers, the Palestinian and the different ones from the World Center Kitchen. And there was a huge boost again in food coming into Gaza. Then now we're seeing another cycle of food being restricted in the north of Gaza. And so I just want to say this stuff is not constant, that there has been a influx, outflux of food. We have done a food availability in Gaza analysis, and this week actually should be out, and I'm happy to share it with your network. But what I want to say is that this has led to today acute malnutrition being in Gaza of around 10 to 15%, so 10%. So it's actually an increase of from 1% to 10% in 1 year, okay? And it is a lot, okay? But as nutritionists, acute malnutrition becomes, in terms of malnutrition, marasmus, and all of the manifestation of it on children under 5 really high is what we've seen in Sudan of around 30%, 25%. So I just want to say that there is a food insecurity in Gaza problem, 100%. Israel and all the actors involved and what is happening in Gaza is definitely a food insecurity. And this I can talk about because I work as a food insecurity person. And it is definitely an increase in acute malnutrition, 100% from 1 to 10% increase in acute malnutrition. But I want to caution against some of the things that I've seen around floating in terms of the IPC. Okay, taking IPC numbers of mortality from other settings and multiplying it and applying it to Gaza, this is not how it works. This is not like, because Sudan, Yemen, we have malnutrition with infectious diseases, with there is a polio outbreak in Gaza, but there is also vaccination in Gaza. So all of that together leads to mortality. And so, yes, I'm not saying that that actually malnutrition does not increase mortality. Of course it does. And of course there is mortality happening from malnutrition and from the combination of malnutrition and infectious diseases. But I would caution against doing some of this in order to push numbers that sometimes it's harder to back up some of these numbers. The other thing is, I would say, is that that actually what I wanted to say is is that malnutrition has implication on pregnant women, but also a multi-generational impact. So there's an intergenerational effect of all of this exposure to malnutrition that's not only linked to mortality and will have a long-lasting effect. That has been very well studied in the Dutch hunger studies in World War II and so on. So I'm not going to go into the literature of nutrition, but just to say that there is multiple effects of it, including people who are diabetic, right? So type 2 diabetic people need proper food and different management for insulin. And so I would also cautious against to talk about malnutrition, how that implies and all of that. But also, sorry, one more thing is to bring up injuries and proper injuries. So for them to heal, need proper nutrition. And so that all plays a role, of course, in mortality. So yeah, I hope that was what the question.
Yeah, I mean, I know that's a topic in and of itself. Yes, Les, please go ahead.
Can I just add one thing to what Zeina just said? Everything that she just said that is happening, like let's say a polio vaccination campaign, it makes sense. It has value, but everything has an opportunity cost. And in a place as stressed as Gaza, just realize for everything like that we do, we suddenly aren't bringing insulin in as effectively, or we aren't able to handle people whose feet are swelling up and they're having congestive heart failure or whatever it might be. So like this is a tricky game, and documenting is sort of part of the way to get it right.
We have so many questions, which is a good thing, and I might only be able to take a few more. I have several on this study that came out in the Lancet over the summer. And Zeina, you had just mentioned this issue of crude estimates. Now, this study made a very big splash when it came out. They essentially used a crude estimate from studies that have found that for every direct death, for every direct mortality in conflict, there's 3 to 15 times more from indirect deaths. And so they kind of just applied that to the current death toll and came up with this, I believe it was 186,000 number. This study has generated a lot of conversation, and I would love to, and I think many people in our audience would love to just hear any of your comments on that study and what your thoughts were about that approach.
Okay, yes, sure. So first of all, I want to say that even one of the author at a certain point mentioned that these are projections. So I think this study, it's a commentary, was actually viewed in different ways and people interpreted it in different ways. So first thing I would want to say as a researcher is studies with methods, limitations. Why did I keep saying I have 70 pages of limitation in the methods? Because this is how epidemiology works, okay? And this is how research works. And not to say that the number is not actually very high. That's what's happening in Gaza. It is 2% of the population. First of all. Second of all, a multiplication factor that was used was actually based on Burundi and East Timor in 1974. And I would say, and other people might have different opinion, is that the baseline in Gaza is different. We had very high vaccinations, we had high NCDs. And so using multiplication factors sometimes is not how epidemiology works. The third thing I wanted to say is that there is time progress. So as you saw Les's numbers in Iraq, it's not at the beginning where all of this happens. And so there's a time progression to diseases and deteriorations of systems. And it's like dynamic. And I would also say that argue actually that this number was taken by different people to mean that this is how much mortality is in Gaza, whereas it was just an indication of what could be happening. And so I would also say, and I don't know, this is as an advocate I would speak today, is advocacy might work best when we have good science backing it. And at the beginning of the war, when the ministry have put the numbers, these numbers have been used by the ICJ, by the South African, to actually basically proceed with the genocide. What I would come today and say is that what I would advocate at the end is to say good methods, good research with limitations, and to push some of these aspects into this is more complex than coming up with a number. And so maybe this is not an answer people wanted to hear, because some people had that in the chat. They want to know how many deaths happened. But I think Les said it really nicely, is in terms of, we're talking today about 42,000. It is an underreporting. I did, as I mentioned, a capture-recapture analysis. Hopefully it comes out in a few weeks about non-traumatic death and people under the rubble and some of that. But at the end of the day, it is 2% of the Palestinian population in Gaza that was killed. It is what we've seen and the patterns we've seen. And I would argue that what would help is pushing proper methods to push the like what's happening. And already what's happening is horrifying. And so this is what I want to say, is that sometimes I've seen that, of course, we want to show how horrible the situation is, and it is, and we have methods to do some of this. Thank you.
Les, did you want to add to that?
I think her answer was brilliant. There have been wars in Kosovo and Iraq and Bosnia where the majority of deaths were from violence. So there's a huge spectrum. There's a lot of assumptions that were built into that article.
Yeah.
It got us thinking, but it might not be accurate.
Great. Thank you so much. I'm only going to have about time for one last question so I can ensure that our wonderful speakers have time for a closing argument or a closing statement if they'd like. And this is on the question of civilian versus combatant deaths. Now, of course, I think the IDF would argue that many of these deaths are combatants or otherwise we're in situations where combatants were present. Les, in your experience, and Zeina, I also want to touch on your experience as well. How do epidemiologists, demographers, others look at this distinction? And again, how does this come out in in retrospective research that's able to be done in the future?
My strong impression, based on like a bunch of anecdotal tales, is that we're really bad at this compared to measuring deaths. Like it's not something we can do, particularly within the subcategory of adult males. That is why we have so many reports saying, oh, and 70% of the deaths in Gaza have been women and children, or whatever it might be, because it's very hard to argue that a 14-year-old girl or an 80-year-old woman was a combatant. So It is really hard. It normally can be done more accurately after. We saw in Iraq that surveys done by the Ministry of Health had a similar number of deaths reported as done by outsiders, but way more violent deaths because people just couldn't quite bring themselves to say my son was killed by you, and therefore it is hard. It is quite hard. We'll get better information over time, but we'll never know the exact breakdown within that adult male category,
Mm.
I think.
And Zeina,
I
please.
completely agree with Les. This is the first question people ask. Sometimes, how many of them are combatants? And this is not known. We do not know in Gaza in terms of from the data. I'm talking about the data itself. And so I have nothing really much to add to what he said.
Thank you so much. And apologies to those of you whose questions, and they started really coming in quickly in the last 10, 15 minutes that I could not get to. The projections work, I think somebody asked of Zeina is, I think Denai put it in the chat, but it is available at just gaza-projections.org. And so you can see a lot of those figures in more detail. Les has published extensively and spoken extensively on this as well. And I hope we continue to hear both of their voices as unfortunately we are continuing here. I want to start with your closing comments, and Les, if you'd like to go first.
Sure. My closing thought is I've been thinking about this for a few weeks in anticipation of this panel. I think I've been in 11 hot war zones, and I'm struck that every one of them looks really different now than it did when I was in it and primarily fixated on being terrified I'm going to get my interviewers killed or whatever it might be. And in some cases, like the Rwandan genocide, actually, it looks like almost the exact opposite narrative as I would have said in 1995 now. And the way, like happened with Napoleon's march on Moscow, the way society decides, wow, invading Russia in winter, that's a really bad idea, is data and perspective. And I just can't thank Zeina and her colleagues enough because across the globe, like the most valuable insights we've had from Gaza, like half of all the valuable insight that didn't come from the Ministry of Health has come from the London School of Hygiene. So whichever side you favor, like I'm not like saying this for one side or the other, history will be better and we as a species will be wiser for what Zeina's team has done. And I'm so impressed with that. Thank you.
Zeina, you somehow have to follow up on that.
I think he said it in terms of yeah, I have nothing to follow up on that. Thank you for that message. But I would say at the end of the day, maybe good data, good measurement, good analysis, good methods, building these and using them, whether in Sudan, whether in Iraq, whether in Lebanon today, good health systems, projections using all the work people have done in the field of epidemiology, public health for years, builds us all to be able in times of crisis, whether it's a climate change crisis or others like what Les has mentioned, some of the climate change, into the next big catastrophe that's happening. And so hopefully there's a lot of times where you would feel, what are we doing? And is this even anyone hearing us? And I do ask myself that every day, probably, but hopefully this war will end in Gaza and the war that now started in Lebanon soon, and that we're not just adding more flags in protests. So our voices as a community of public health should be always raised, and talking about people who talk about mental health and know this should talk about it. And people who talk about mortality should be active in their own small communities, even if it's just feels sometimes that we're not doing anything. So thank you, Les, for the comments actually at that. Bye.
Thank you, Zaina. I think ending kind of on that call to action is a really important note to end on. I want to really thank our speakers, Dr. Les Roberts, Zeina Jamaluddine, for your incredible work, your experience, for answering our questions, and for sharing and helping us, I think, maybe get a little bit of a clearer view on what we're seeing. I want to also thank the co-sponsors of this event, the Center for Middle Eastern Students, or Studies the Religion, Conflict and Peace Initiative at the Harvard Divinity School, and the Carr Center for Human Rights Policy at the Harvard Kennedy School. For those of you who have asked, this has been recorded. It will be posted in a few weeks once we are able to get the closed captioning. So if you missed it or you'd like to share, it will be posted on the FXB website under the Palestine Program for Health and Human Rights. Thank you to everyone who helped organize this, everyone in the audience, again, to our wonderful panel, and thanks to everyone for your time today. Have a great rest of the day.